0.05 is, but the 0.05 in the Indian study, but whatever patients you have seen, you've noted that they do complain of some accommodation problems and photophobia. I think accommodation problem. So what if we start that 0.1% BD right from the beginning, 0.01% BD right from the beginning?
So there are two aspects to this question. The first aspect is that whether we should start BD or whether we should start with 0.05%. Now,
Yes.
0.05% normally does have problems of accommodation, but that is what I meant to say was that when you give 0.01%, in my practice, I have seen maybe one or two patients over a period of so many years. It has now been almost 10 years that, I have been practicing myopia. And I think there have been one or two patients who did complain of near vision problems, one or two max. But with 0.05%, yes, there is almost 8 to 9% of the children. So 8 out of 100, not a very big number, but a sizable amount. So 8 to 10%, I would say, do complain. So if you feel that there is a patient who is progressing very fast, and they have actually devised a term for that, which is known as super progressors. So if they are super progressors, more than 0.75 or 1 diopter per year, maybe you can start 0.05 at the beginning. And if patient, and we can always sit and talk with the patient and tell the patient that, if you have this complaint, we may reduce it to 0.01%, or you can start with 0.01% twice a day. The problem is that you will have to wait for 6 to 8 months or maybe 9 months before you believe, or before you have the data to prove that, despite using 0.01%, he is still progressing. So both ways are fine, because 8 to 9%, yes, 8 to 9% is a big number, but 8 to 9% is only in our experience. Maybe it is not that much with all the population base. 8 to 9% incidentally is almost similar to the number of patients who do have, AIUN following Ozempic. So, I mean, it's a big number. I'm not saying 8% is a small number, but this is a reversible thing. So both ways is fine. If you feel that, patient is very apprehensive, and also, if I may add, what I have also done with 0.05% is that whenever I give 0.05%, and if patient comes back saying that I have a problem of accommodation, I do suggest that, we can always give progressive classes.
Okay.
So there have been patients where we have given progressive classes with 0.05%.
Okay. So just again, one basic. If there is 0.5 increase in myopia, you will say it's a progressor. But if it is 0.75 over a period of year, then you will say it's a super progressor.
I mean, these are all terms.
I don't know. But actually, what happens now? This is clinically when should be this thing say shift over.
See, there is no, what I always keep telling in previous batches also, I keep telling that, all of us who are right now into discussing, and I don't really say that this is a class, you all are colleagues, and we are discussing the subject, and we are some of the people who have started this, and maybe there will be different terms, more knowledge, more insight in coming years. Both of us, Uday, Nitin, Dr. Maheshwari, all of us, Dr. Chandrakishore, we may sit and we may be laughing after 10 years that, we were calling this super progressor and actually this was something else. So, you can call super progressor because that is a fancy term. And yes, doctors don't have much in life, so they use these fancy terms. Super progressor. It's a good term. Nothing wrong in... but you are right that, a difference of 0.25 and they become super progressors.
Yeah. So no, it's just, I mean, here we can, I'm clearly ask whatever you want to ask. So I thought might as well clear it out.
I mean, no. See, that's why I also try to remain, uninhibited. And I just tell you that, this is not really a class. And we all are back and forth sitting, discussing, making new terms and new terminologies. There is no such term. 2 years back, there was no such term. And so everybody is just trying to find out better ways and better means to classify and to define. So even in my lecture on pre-myopia, I was trying to talk about type 1 and type 2 pre-myopia. And I know that, I think I was presenting somewhere and somebody actually told me that, Dr. Saab, there is, what is the basis? This is just arbitrary classification. And I do tell that, yes, this is perfectly an arbitrary classification, and maybe 2 to 3 years down the line, classify pre-myopes based on something else.
Yeah.
So nothing wrong in that. I mean, we can keep on evolving.
Okay. Okay. And my second question was, so we should start BD only after we see that there is no, the progression is present, right? BD dose.
You can start BD straightforward, madam. You can start BD if you feel that progression is little too much. If it is more than
The younger child, maybe
0.75, you
we
can
can
start with
BD.
BD.
As in a younger child, maybe we can start BD.
Yes, we can start with BD and then come to or you can move to higher concentration.
Okay. And in preterm,
I didn't get the question. Please tell me again. Sorry,
my,
I was.
the second part of my first question was whether we can start BD as a primary treatment, and that you answered. And another
Yes,
question,
yes.
and another question was, can we start in preterms?
Now preterms are a little different ballgame. So the problem is that if we have a documented axial elongation, if we have a documented axial progression, so nobody says that preterm babies cannot have axial elongation, or they cannot have two things together. Like they can have myopia secondary to the crowded anterior segment and also secondary to the axial elongation. So if you feel that they are having the progression secondary to axial elongation, you can start atropine. Again, the same principles are there. You have to document that they have suggested it doesn't work in ROP patients, and there are other studies which there are few of them which have suggested that it does work in ROP patients. Broadly, it will work only if there is axial elongation and not corneal, curvature myopia or index myopia or crowded anterior segment myopia. The only difference between ROP babies and normal babies is there's a small difference. What happens is that in the ROP babies, the anterior segment of the ROP babies is very small. So even a very small change in axial length makes a larger difference compared to a normal kid. Now, how it is difficult to understand? It is easy to understand if we take into consideration the effective lens position. So, if you move the lens ahead,
Right.
and if you reduce the anterior chamber depth and you reduce everything, you basically try to think that there is a relative posterior megaophthalmos or relative anterior microophthalmos with a curved cornea. So with a cornea of 48, 49, and there is another patient who is having normal cornea of 44, the change in axial length and also the lens is also anteriorly placed. So,
Yes.
I tried to do some work and then so there are, if you go back and see your ROP babies, you will see that normally their curvatures are always more than 46. Nowadays, when I get the patient in my OPD, and if their corneal curvature is 47, I directly ask them whether the baby was premature. I mean, I am that much sure, and it is that much common in premature babies that their curvature will be more, their ACDs will be less, and their lens thickness will be more. So effectively, if you go into Donder's reduced eye concept, the anterior part of the whole eye is a higher refractive segment compared to a normal eyeball. And so even if there is a small change in axial length, it sort of augments.
Okay.
I don't know whether
Sir, do you use a handheld keratometer
I have
to document the
confused
curve?
the issue or I have sorted it out. But my point is that if there is an axial elongation and if you feel that axial elongation is over a period of time, start atropine.
Okay, sir. Thank you. Sir, to document that and
Yes,
corneal curvature, are you
I
using a
use
handheld keratometer?
Yes. I'm
Okay.
using both handheld keratometer, and if the child grows up, I will be using the normal keratometer.
Regular keratometer. Okay. Thank you.
Yes, Dr. Uday.
Sir, actually, first of all, I would like to congratulate you for doing such a monumental work and express our gratitude that you are taking us along with you. Uh, Regarding when I was going through your presentation,
Your voice is breaking, Doctor Sir.
एक्चुअली यही हो रहा है कि मेरे क्लिनिक के बाजू में वर्क चालू है। पहले अच्छा रेंज आता था, इन दिनों जरा गड़बड़ हो रहा है। मैं ऊपर जाता हूँ मेरे घर। गिव मी जस्ट अ मिनट प्लीज।
जी सर।
हाँ प्लीज।
We can take more questions if somebody else has a question till that point of time. Nitin is there?
Yeah, Jitu bhai.
Dr. Maheshwari?
Hello. Hello. Am I audible?
Yes,
Yes, yes.
Sir,
Yes,
you said,
yes.
sir,
You're
you
not
said,
visible, that's it. Maybe because of the dark. No, you are visible.
you said, sir, you start atropine at the age
Nitin, you are
of
not
4.
audible. Yes.
Am I audible?
4 years, yes.
But sir, in my practice,
4 years
actually,
or above.
4 years and above. But in my practice, actually, what I do is, if I see a child, let's say 2.5 years, and if the child is, let's say 3-4 diopters, myopia or more, we get so many kids like that also.
Yes, yes.
So
Yes,
in
very
those
true.
cases, yes, in those cases, actually, I start atropine because what I think is it is really difficult to get
Should
their
we wait
axial
for 6
length.
months or not? That is the question, right?
Actually, I don't. I straight away start. What is my logic is because see, it is very difficult to get their axial lengths done. Secondly, even the refraction, we do it on retinoscope, and the child is not at all that much cooperative. So plus minus
Yes.
0.5 here and there, it is always. I mean, it goes hand in hand. Hello.
So the question is whether, whether we can start it in the first instance or not, right?
If the because see you told that if the myopia sets in at a younger age, the chances of progression are already more. So why not we can start at a means at the first instance only.
But what if
Because
they are congenital myopes? They are high myopes and with congenital myopia.
No, but how would you know that he's progressing or not? He may not progress. So 20% of the kids don't even progress.
but then
Congenital
what is
myopia.
the but then what is the harm? If it means 0.01% doesn't have any, I mean, side effect. We can anytime stop it if it doesn't progress.
No, but then if it doesn't progress, you would say that it is because of the drops. It is not otherwise. See, that is the problem, no? See, the
But then
problem is... Acha, let us take it other way around. If you don't start the drops, how much harm you are going to create? Not more than 0.25 diopter or maybe. Yani if he is a super progressor, supposed super progressor, you will create a harm of maybe 0.3 diopter. Am I audible?
yes. No, but have you encountered such kids like who you see at, let's say, 2.5, 3, 4 years, and they are like 4-5 diopters at the first instance, and they won't progress.
Sorry, I didn't get the question. Sorry, Nitin. Please tell me again.
What I am saying is, have you encountered such kids who are like in the first instance, you see 3 years age kid and having, let's say, -4, -5 diopter myopia, and and they don't progress, means you want to wait for 6 months, means have you seen such kids who don't progress if they are so young and having so high myopia?
See, the simple thing is that I want to make sure that patient has to progress. If he is not progressing, no, how high myopia he can have? You know, he cannot have higher myopia. How much high myopia he can have? He cannot be. Another addition of minus 0.25 would be there at max. Another thing is that when you are trying to convince the patient, see, you are trying to convince the patient that myopia would progress. If it is not progressing, what are we treating? We are treating the progression. We are not treating the myopia. So we are just treating the progression. What we are trying to say is that, you know, myopia would progress. So patient would straight away tell you, boss, myopia is not progressing. Atropine 0.01% would reduce the progression. It will not change anything to the myopia. Suppose if his kid is in that 20%, why is he putting those drops? And if we don't put drops, and suppose if he increases, his power increases, regardless, his power will not increase more than 0.25 or 0.3. And when he comes to you, so what I do is when he comes to me for the first time, I tell him that, boss, you have got myopia. There's a very good chance, there's a good 65 to 80% chance that your myopia is going to progress. So you start environmental modification, which are the most important ones. Second thing is I start them, I keep telling them that you reduce the near work, you forget about near work. The third thing I tell him is that, you know, you have to sit outdoors. And then when he comes back after 3 months or after 6 months, I tell them that your myopia has progressed. Did you follow those things that I told you? And he immediately says, no, I have not followed. And then, and now this guy is desperate because now he understands that his myopia has already progressed. What we had already told him, that is what has happened actually. If I start atropine in the first instance, I have no idea whether his myopia was going to progress or not. So technically, you can start atropine, but I would still wait for progression, document the progression, and tell him that, you know, your progression was 0.3 millimeters, and with atropine now it is only 0.1 millimeter or 0.18 millimeter. Because otherwise, I have no clue, no idea how to change the treatment if I want to change the treatment, or if I want to increase atropine, or if I want to add on another pair of lenses in that.
And the second concern is, like, in these small kids, sometimes we have to take retinoscopy refraction. We cannot make them sit on the auto ref. Okay. And then they are not that much cooperative also.
Yes.
So that 0.5 diopter will go, I mean, here and there anytime.
They may not be cooperative, very true.
So then how can you say justify that he is progressing?
See, that is where the importance of axial length comes. See, if you are not very sure of his accommodative effort, and not every time you can do his atropine refraction, we have to check his axial length. His axial length is not going to change without his change in the glass power.
But then in these kids, how do you take the axial length? I mean,
Then Nitin?
how do you take the axial length in these kids if they
Which
are not
patients?
sick, in these uncooperative patients, small kids? They are not sick in these uncooperative patients. They are not sick in these uncooperative patients.
patient See, if the patient is not cooperative, it will be extremely difficult.
Okay.
If the patient is not cooperative, it will be because it is extremely difficult if the patient is not cooperative, not willing. See, these are all gray area cases. These are not the cases where you would feel or you would think that patient you can manage them properly, because these are not really the patient whom you can easily talk about. These are difficult patients. If you can't take axial length, if the visual acuity itself is difficult, if you are talking about refraction, that is the reason we normally take patients who are more than 4 years of age, who are cooperative for it. Am I audible?
Yes, yes.
Yes, sir. Yes.
Yes. Actually, I have one of my computers is having some trouble, so I have logged in from 2 devices. See, if you can't do axial length and if it is difficult, then it would be very difficult. Those are not the patients who would be, who will have a predictable course. It will be extremely difficult for you to find out what is going on, because you yourself don't know what is going on. Power is increasing, power is not correlating with axial length, then the whole premise goes away.
So I just wanted to be on the safe side. We can start. I mean,
Yeah, you can start. See, at the end of the day, whatever you do, you should have answers for whatever you are doing. If you have, as long as you have so there are more than one way of practice. As long as you have justification why you are doing it, you can of course do it. See, both giving atropine and ROP babies, giving atropine in the first instance are gray areas. Anywhere, any conference you ask this question, it is going to be highly debated, mainly because most of us have different experiences. It is easier to practice based on evidence, because whenever the patient comes back to you and tells you that, why did you start, you should have an answer. That's it. Nothing else matters. His power is not going to increase that much in 6 months that you don't have an answer for that. Also, you have already told him when the patient came to you in the first instance, you told the patient that, boss, you have got myopia, your power can increase, and when his power increases, you will tell him that your power increased. I already told you your power was going to increase. So you are not following environmental modification, and most of the literature, most of the discussion clearly says that environmental modifications are more stronger if they can be implemented than atropine, and then even the myopia defocus lenses. So near work, outdoor sitting, all those issues, if they do it properly, we can ensure that sometimes they may not even progress at that time. And after 6 months, when you tell them that you have not progressed, they become very happy and come back after 6 months with progression. Because now they feel that, oh, I will not progress. I'm good. And then they do what they want to do, or rather what they were doing before. And then they come back with progression. Yes, Dr. Uday.
So, am I audible now?
Yes, sir. Yes, sir. Yes, sir.
So, first of all, I would like to congratulate you for doing such a monumental work and express our gratitude that you are carrying us along with you. Uh, while I was going through your presentation, when you used atropine in pseudophakic eyes, just something happened. I thought of his first thing that reduction in reduction in myopia or slowing axial length progression in such cases actually refutes the mechanism of changing the length,
Accommodation.
right?
Yes.
Yes.
Yes. Yes.
And other thing what came to my mind was that in all those you must have done PPC, right?
Yes, yes, all of them had
Whatever we
posted.
do, whatever we do, there would be some micro leaks in between the PPC and the lens, from which the atropine might have greater or better access to the posterior chamber, and that
Maybe,
might be the
very true.
that the axial length
Quite possible.
lengthening is, yeah. So
See, actually, what I think is that, the theory that it does affect accommodation, or the two articles which I discussed, both by, I think there was one by Dr. Saxena and one was by Havel et al. So
Mhm.
both the articles, basically what they were trying to say was that there is some effect on lens power.
Okay.
Although when they were anatomically measuring it, it was not very significant. So what I feel is that particular effect on lens power is actually probably the rebound which occurs when you stop atropine.
Okay.
And so that little bit of 0.25 or 0.5, and it is variable from patient to patient, and that is the reason when you increase the concentration, the power of the amount of rebound is higher, because the more the concentration, more would be the effect on lens thickness. Now, Dr. Rohit Saxena in his article says that they have used 0.01%, whereas the other author has used 0.1% for a short spurt of time and then 0.01%, and they have compared it with a control group of 0.01, where they have suggested that 0.01 doesn't make a change, but if you give a small bolus of 0.1%, and then if you give 0.01%, it makes a change. And then there is a third article which suggests that it changes in a particular group of patients, and in another patients it doesn't make a change. So probably it is not that it is not making some difference. I think it is very difficult for the machine to measure lens thickness in 0.02 millimeters. 0.02 millimeters is really a small number. That too for lens thickness, it is a dynamic structure. Lens in young age is quite dynamic. So maybe it is important for the rebound, which has not been discussed much in the literature or anywhere. And I also I don't talk much about it because we are not really sure that this thing is happening actually.
And also, if you permit, regarding the axial length measurement in very small kids, previously also I had mentioned that we can do immersion in this kid, and Dr. Nitin, I had done it when I was doing my practice in the initial days, because I didn't had access to GA and EUA and then do axial length measurement. So what, this may sound little crude, but it is really effective. You have to, just like what we do during ROP screening, you have to they, wrap the kid in that way. You will need two assistants. Actually, I am assisted by my wife. She herself is a.
She's a glaucoma expert.
So what we used to do, that we used to open the eyes and we used to apply the Prager shell, and then when we um, put the water inside that syringe and when we push it, the child has got curiosity. When, as soon as the chamber is filled up, the light starts and the child directly looks into that light, and we get the axial length measurements. And it had worked for me very nicely, because obviously in my private I didn't had those numbers of pediatric kids, pediatric cataract patients, but whomsoever I have operated by this IOL calculation formula method, the results were very pretty good. But though it is little crude, but it can be done if you are that much desperate to measure axial length. Otherwise, it's all okay.
So any other questions?
No, sir.
Okay. So maybe I think we have seen the videos till atropine. The next videos will be on optical options, and after optical options, I will be sharing a video of ortho K with
Red light.
red light. I think optical options, ortho red light, we can take a common this thing because they are almost similar. The ortho works on the similar principle as the defocus lenses. If somebody wants to present, I can put up some of the articles. If somebody is interested to read those articles and want to talk or present, I can share more articles also. And red light therapy currently is not available in India. I have talked about it. I will also be sharing a video which was the Zoom meeting with Dr. Chandrasekhar Chavan, who is working on red light even otherwise also. So that will be a nice talk. So we can discuss it maybe not next week, but after that week, because I will be sharing one video on optical options, Zoom meeting on optical options, and then I will be sharing another the video of Dr. Chavan and of my video on optical options with Ortho. So that will be for another 8 to 10 days. So if there are no questions, maybe we can stop. If there are any
Actually, what
questions, we
is
can take. Yeah, Dr.
Um,
Maheshwari, Dr. Nitin.
yeah, yeah.
Yes,
Sir, this is Dr. Maheshwari.
yes,
Sir, I
yes, ma'am.
just wanted to ask if we have started the patient on atropine 0.01%, and
Yes.
if the patient have that accommodative problem, so immediately can we stop or better to wait for 2 to 3 months and then to see whether
There are two
they're
ways. See, that's one of the reasons why I always tell that, you can, before starting, if you are starting atropine, you should always measure near point of accommodation. So if you
okay.
already have a reading that near point of accommodation was, suppose, 6 centimeters or X amount, and if you feel that near point of accommodation has actually receded a lot, see,
Okay.
if it has receded by 2 or 3 millimeters, you know that, that he will be able to manage that. It is not huge.
Okay.
But if
Two
you
to
feel
three
that
doesn't make a that difference.
yeah. So
Okay,
if
sir.
you feel that it is making a lot of difference, then you can immediately stop it. Otherwise, you can tell him that okay, we'll wait for another 15-20 days. So that
Okay.
is where it that is where it helps when you do the pupil size before starting atropine. Because once the patient comes, I mean, I'm talking about the similar lines if patient complains of photophobia. Now, you have the pupil size pre-atropine of, say, around 5.2. And now it is coming out to be, suppose, 7.2. You know that, 5.2, 7.2 is a huge, there's a huge difference. If it is 5.2 and he comes back with a size of 5.8, you know that it is not much. Maybe he's more sensitive and he will come along. Within a couple of days, he will come along. So based on that, you can decide. You can talk with the patient, talk with the parents. If they are very upset that it is not working at all and the kid is very cranky, we cannot do it. You can, in today's world, it is better to be safe than sorry. You can
Yes, sir.
stop it and tell them that atropine is creating side effects in him. Let us go with another option. Or if you are using higher concentration, you can lower down the concentration.
We can go to the optical options if they're
Yes,
not.
yes.
Uh,
Yes, yes, you
okay.
can definitely go to the optical option because you have already informed the patient that this atropine can, in rare cases, can cause this, and because it has caused this problem in this patient, we can move on to another option. And they normally, when they listen to the cost of that, they immediately say it's fine. You can go ahead. We will wait for another week, maybe the boy will come along with atropine itself.
True, sir. I observed that when once we go to the optical options, they take a step back.
Immediately come back. Yeah, yeah.
Yes,
I mean,
sir.
those are
Yes.
practical things. We also understand their problems, not that we don't support their problems. And if we don't understand their problems, we would have started giving opticals to all the patients. No, we would have made mandatory that okay, glasses are the only option, and atropine is of no use. But because we understand the economics in our country, we know that not everybody can afford the glasses are truly expensive. So even people like us have to think at least once before thinking of spending some 15,000 for a pair of glasses, because the kids may break it. That is the whole point.
Yes, sir. Thank you.
Oh, okay, ma'am. Nitin, you are asking?
What about this methylxanthine?
So the problem, so methylxanthine is a good drug. It's a wonderful drug. Methylxanthine, 7-methylxanthine was initially started, I think, way back in 2008 or something, or 2012, I think, in Denmark. And I tried to contact the author. He said that they cannot send it to the country. 7-methylxanthine, the drug API is in Europe, and Indian manufacturers are not able to access it. The good thing is we talked with Antort people. They said that they are trying to make they are trying to make 7-methylxanthine eye drops, and so that's fine. I was trying to tell them that it is already available in oral oral formulation. Why not try that also? So 7-methylxanthine does work on modulation of scleral fibroblasts, and so 7-methylxanthine is a good drug if it is available. Right now, it is not available in the country. So since it is not available in the country, we have to just wait and watch. But it's a promising drug. Multiple trials, at least from the host country, Denmark has done multiple trials. There was a renewed interest in 2023 when they published an article in BMC Ophthalmology. So yes, 7-methylxanthine is something which should come in the country. Let's see when it comes. But there are good clinical. I mean, at least there are 2-3 groups who say that it is working fine.
But the dose is quite high.
But we don't know what is the active. I mean, dose is high, but it works in that dose only. It is like citicolin. Citicolin also works in same amount, same 500 milligram.
But 3 times, they were saying 3 times a day.
So neurologists will prescribe citicolin 500 milligram 3 times a day only. We don't know what any drug, if it is the dose is the dose. We don't know what is the dose. See, that is beyond the scope of clinical ophthalmologists. We have to just listen to the pharmac guys. Whatever is the dose is the dose. We can't argue with them why it is 500 milligram.
Yeah.
Maybe
Actually,
when you give 500 milligram, the active component of some minimal amount only goes, or that much amount is needed to get absorbed with. See, I am just hypothetically saying, I have no clue, no idea. So
yeah,
just
यहाँ पे तो actually
one-to-one
atropine
discussion.
atropine once का ही compliance issue है.
Maybe once the drug comes, maybe you may get a sustained release tablet, ceticolin SR.
Okay.
See, वो तो as they say, no, आविष्कारी आवश्यकता ही आविष्कार की जननी है. So once you see, it's all about first you get 7-methylxanthine in the country, no. First we have to get that drug in the country, and see, I have been trying. This is almost 6 years since I have been talking with people about 7-methylxanthine. People have not heard about it, and once you tell them, they say, oh, this is. I mean, this is. I tell them this is there since 10 years. This is not new, not at all new. This is already there since 10 years. And showing very good results. That is the whole point. Yes, Dr. Sir.
जीत भाई एक accommodation lag, can you explain with an example?
See,
Accommodative lag.
accommodative lag, you have to measure, you have to ask the patient to look at a target, and you have to do the retinoscopy. Whatever power comes, that is accommodative lag. It should be 0, ideally.
I just saw a YouTube video. They were saying that the difference in the dynamic and the static retinoscopy, that would be the accommodative lag.
But that would be the same thing, no? You dilate the patient, and whatever is his refraction, you give the refraction to the patient, and then again do the retinoscopy. So whatever comes, see, once you give
Okay.
the prescription to the patient, then he is 0. He should be 0. If he should be 0, and if he's showing some amount of accommodative, if he's still showing some plus, that is the lag he is having. He is not able to accommodate that much. So,
Okay.
I said technically, if we go See, this is the teacher student language. This minus this is equal to this. But in clinical words, if you give glasses to the patient, and then if you do his refraction for a target where he should be accommodating, but why will he accommodate? He is already using his prescription, right? So he should be conjugate to that particular point, but he is still having plus say plus 0.5. So whatever power he has, this is the amount of lag that he is having.
Okay. So let's say if one patient is there who is having, let's say, minus 2.5, he is wearing minus 2.5, and if we want to measure it, so we'll ask him to accommodate at a distance of 40.
At 33 centimeters, 40 centimeters.
Centimeters. And then there should be some plus movement.
Yes.
Then there will be
There can
accommodative
be minus movement. There can be minus movement also. If there is minus movement, it is accommodative lead.
lead.
He is over accommodating.
Yes.
See, accommodative lag, I always try to talk about it so that people are aware what is going on. Otherwise, accommodative lag is of no use when you give atropine. We have done multiple work on that, found out accommodative lag does not change with atropine 0.01%. So, should we do it? We should do it so that once we are using it, at least we know that his lag has increased. Like Dr. Maheshwari asked that, what if patient complains of near problem? So if his accommodative lag before you gave atropine was say 0 and now it is plus 3, it means that he is having a serious problem. But normally it doesn't happen. At least I can give you an experience of at least 1,000 children. I have prescribed more than 1,000 children. It doesn't happen. Accommodative lag doesn't change much. Some patients, yes, I understand, but not many of them.
Sir, can I ask?
Yes, please tell.
Actually, sir, a question is regarding this compliance issue. Many a times what happens, you have actually patient parents, they are very much motivated that they want
Yes.
slow down their myopia and all. And then in initial visits, they would ask for what measures you can do. And then you prescribe atropine. What happens after 3-4 months, they would discontinue.
Very true.
Once again they would come, so we would again tell them that you have to use this for such a long period and then only it would be helpful for you.
Useful, yes.
They again go and again they will come back after 6 months, 8 months after stopping the atropine. So what to do in such cases? Like these are very rampant cases, at least in our part.
But we can't do anything. See, we can, there are two aspects to it. One aspect is that, you can only show the way.
That's it.
You should not take the blame for worsening of disease. I had told you the same thing when we met at Moscon also.
Yes.
Never take the blame for the patient. Never go for victimization that, this was my mistake. This is not our mistake. We are doing best for the patient. We told the patient that you have to put the drops. Now, second thing is, I will tell you a very interesting thing. I think I was telling that in Surat also. What they have started doing is, people are so innovative. What they have started doing is, they have started putting atropine 1% twice a month. So, yeah, so there are some people who are doing trial with that. I just overheard. I was talking with somebody, I think at APA this year, and Rohit told me that they are using atropine 1% on 1st of the month and 15th of the month, and again next month 1st of the month. So this may come up. You never know, and this may become the standard of care. We don't know. I mean, if it is working, and if it is increasing the dopamine concentration and working well with near, there's no problem in near work also. Fair enough. I don't know how to titrate and how to find out how much dopamine it is releasing. But as Nitin also asked that, how to take 7-methylxanthine thrice a day. when putting atropine once a day is a trouble, using and taking 3 tablets a day is like huge.
Yes, yes.
Sir, I have
But
one query.
yes,
Uh,
ma'am.
so do you give any information sheet to the parents, or do you take a consent from the parents when you start atropine?
I used to do it when I was doing the studies, when I was using 0.05%, I was doing it.
Okay.
Now, since it is DGCI approved, we just tell them that these things can happen. Honestly speaking, over a period of time, I have become more and more bolder in the sense that I know that 0.01% is not going to create a problem. So right now, I am a little bit skeptical about 0.05%. I tell them little bit here and there that 0.05 may cause photophobia and near vision loss, but with 0.01, I have become little, I don't, I used to give a sheet and everything. But now I have, since years, I have, since couple of years, I know 0.01% is not really a problem. So 0.01% के लिए बहुत,
There's no
we
need.
don't think of much. 0.05, maybe we are new still. It has been 4 years, but there have been patients who had problems, and so we are a little bit scared of 0.05%. So we try to tell the patient that this can happen. That's it. वो
Okay.
sheet or वो sub system was there, but now we really don't go much into it.
Okay, sir. Thank you. Thank you.
ठीक है, good. So we will maybe call it a day, and